But his video is not available. उसका नाम भी panel में दिख.
Sir is joined, sir, already.
But his audio, I think, will not come.
और एक बार somebody work on Dr. Tripure, sir.
वो अभी connect कर रहे हैं ऑडियो.
हाँ सर आ रहे हैं, ऑडियो कनेक्ट हो रहा है. ऑडियो.
Sir, welcome.
Welcome, sir.
Namaskar, welcome.
Sir, namaste. Welcome.
Audio is connecting.
Sure. So Dr. Rai has come. We can start.
Yes, sir.
We have lost 4 minutes. We'll be very quick, right?
Yes, sir. Sure. Chintan, roll the slides. Start the slides. 92nd edition of this Thursday musings. Let me hand over the session to Dr. Tufan Patti sir. Everyone is on mute except the host and co-host. Please post your questions in the chat box. The recordings will be available later on. Sir, over.
Thank you, Alim. Next slide, please. Please move on the slides. So move my slides or slide also. I have been given this meeting by Dr. Alim Siddiqui, under Treasurer of IPS, and he is one of the moderators. Next slide, please. And Dr. Amrit Pattadusi, the other moderator, both of them are Professor of Psychiatry and eminent, vibrant members of IPS and Executive Committee members. Please move on. Please move on. Then next slide. Next slide, please. So we have got our chairpersons, Dr. Naresh Nevinani, Additional Professor of Nature Psychiatry, AIIMS Jodhpur. His experiences and activities include he is the Sub-Dean of Students' Welfare, AIIMS Jodhpur, and member of IPS Course and Certification Subcommittee this year, Honorary General Secretary, IPS Narjo, Associate Editor, Journal of Mental Health and Human Behavior, areas of interest, child and adolescent mental health, CL psychiatry, and addiction medicine. He has a research experience spanning over 13 years and 885 publications in peer-reviewed journals, 18 chapters in different books, and he has edited 3 books. Fantastic. Awards and fellowships, 17 including Dr. Sardar Menon DNB Gold Medal, Dr. A.K. Kala Award, Dr. Bakshi Award, Dr. Jishi Oral Award, and Dr. Solanki Award, WPA and Asian Early Career Psychiatrist Fellowship. With this, I heartily welcome Dr. Naresh Nevinani.
Thank you, sir.
And next slide, please. Dr. Tarapad Rai, who is from Odisha, is a very senior member of Indian Psychiatric Society. He is a consultant psychiatry for 42 years. He is alumnus of SC Medical College and CIP Ranchi. He had been the president of IPS Eastern Zonal Branch and IPS Odisha State Branch. He is the winner of Dr. Bimadhar Das Award and winner of Psychiatrist of the Year Award. He had established an NGO with the name Chinta Ochetana. And he is an acclaimed poet in Odisha who writes in both English and Odia and regularly participates in mass media. With this, I welcome both the chairpersons. And before I hand over the meeting to the chairpersons, I am proud to declare that before this meeting, we had crossed 30,000 plugins in Thursday Musings. This is a pat on our shoulder, but I think I should share it with you, and we are very much happy about that. From now onwards, the meeting belongs to Dr. Naresh Nevinani and Dr. Tarapad Rai. Over to you, please. So, Dr. Tarapad Rai, will you introduce the topic? And
Please, sir, please.
Yes, I'm going to. Yes, we are going to talk about opium today. Opium is known to us from our childhood because it was used as tincture opium for childhood diarrhea. So till that is a painkiller in cancer therapy. So there is a lot of therapeutic use of opium, but along with that, the opium is very addictive, and for that, those people become addict, and thereby they get a lot of problem. So I will request our next chairman to introduce the speaker. so that we can hear him.
Mr. Bhabisi, next slide, please. Dr. Yes.
Yeah. Good evening, everyone, and thanks a lot to moderators, chairman, and the entire team behind the Thursday Museum, which is the very much awaited and acclaimed program in the country. And we are fortunate to have Dr. Suresh Kumar sir today for speaking on very important topic. Sir is fellow of Herbert Humphrey in substance use, Johns Hopkins University, US. He has extensive involvement in the field of mental health and substance use as a teacher, trainer, researcher, and international consultant. He's working with several international and UN organizations, UNODC, WHO, UNEDS, on the substance use and related issues. He has assisted substance use disorder prevention and treatment interventions in several countries, Afghanistan, Bangladesh, Bhutan, China, Iran, Kazakhstan, Laos, Malaysia, Maldives, Mauritius, Myanmar, Nepal, Sri Lanka, Thailand, Vietnam, and India. And he has published several articles in the several international peer-reviewed journals. He is on the editorial board of International Journal of Drug Policy. It's always pleasure to listen Dr. Suresh Kumar sir. And since the topic of today is close to our heart, but some or other way it is less discussed, because here what are we going to do today compared to the other conventional treatment model? It is a harm reduction, and which is defined as it is designed to reduce the harm associated with drug use by means other than reducing the drug use. So that's why it becomes more important to listen to all of us. And thank you very much. Over to Dr. Suresh Kumar sir.
Sir, thank you so much. If I'm allowed to share the, slides, if you can, if the organizers can stop the slides and I can proceed with it.
Host, please stop the slideshow.
Thank you so much. I hope the slides are visible.
Yes, sir.
Okay. So thank you so much, Dr. Naresh Nabinani and Dr. Tarapada Ray, for the kind introduction and introducing the topic. It's a privilege to be part of Thursday Musings. And thanks to Dr. Topanpai, Dr. Alim Siddiq, Dr. Amrit, I'm here. Thank you so much for this opportunity. What I'll be doing for the next half an hour is to walk you through the management of opioid dependence. And I'll be focusing primarily on harm reduction. And in this outline of presentation, I'll first talk about a little bit about the background. I'll talk about opioid dependence. The treatment begins with detoxification. I think it goes on to the maintenance treatment of opioid dependence. Primarily, my focus will be on dependence treatment with long-acting opioid agonists or partial agonists. I want to provide the rationale for such therapy. My focus will be primarily on my favorite molecule, buprenorphine, its pharmacological advantages. I would like to have a comparison between methadone and buprenorphine, the two gold standard drugs that are available. And I also want to present some evidence for the treatment with buprenorphine. And I also touch a little bit about what happens with purely abstinence-oriented therapy, like treatment with opioid antagonists like naltrexone, before concluding. So to begin with, my friend in AIMS, their group, Atul Ambekar and their group, have come up with a national survey of drug abuse in 2019. They called out the recent figures in this country.
Suresh sir.
That there are
Sir, many people are saying the audio is a bit low, but in my device, it is quite good. So can you come closer to the mic if something like that can be done?
I hope I'm audible now.
Sir, you are fully audible to me. Some people have complained. Yeah. Sir, you go ahead. Yeah.
Okay. So if you look at the opioid use in the country, there are 2.3 crore users of opium, and about 77 lakh people have a problem use of opioids, and 28 lakh people could be considered as being dependent on opioids. And the primary drug that's being used by the problem users is heroin, followed by pharmaceutical opioids, and then opium. I've been part of a study which has been going on in 15 sites in the country for a long period of time. We try to understand in people who inject heroin and synthetic opioids, what happens to the prevalence and incidence of HIV, because that's a large focus of National AIDS Control in preventing HIV among people who inject drugs. We not only figured out the prevalence rates in certain parts of the country, like in Northeast and West, like in Punjab, is very high, but surprisingly, even in Uttar Pradesh, where we didn't think the HIV prevalence would be very high among people who inject drugs, in places like Kanpur, the HIV prevalence was highest. And if you look at the incidence, which is the recent infection rates that has occurred in the people who inject drugs, the incidence rates are pretty high in places like Kanpur, indicating that there are recent infections going on in places in central India as well as in northern India. So this is the lesson that we have learned. We wanted to do something to reduce the harms related to injecting drug use. First, I'll walk you through the principles of detoxification. And when I do that, I want to just quickly have a glimpse about what are the various opioid agonists that are available. Dr. Ray talked about opium, well known to everybody, taken from the very popular poppy plant, very beautiful poppy plant. And I think direct derivatives of this natural opium will be morphine and codeine. The semi-synthetic preparations are very, very popular with the users. Heroin is one of them. Hydromorphone and oxycodone are the ones which are causing significant public health problems in a country like US. And US is going through a public health crisis, mainly through oxycodone and hydromorphone. And synthetic pharmaceutical drugs used to be very plenty in this country, like pentacillin, propoxyphene in northeastern states of country. Now, methadone and buprenorphine, the useful drugs, also synthetic pharmaceutical opioids, but they are essentially used in the treatment. They're not being abused so much. So if you look at the opioid pharmacology, there are three types of opioid receptors: mu receptors, kappa receptors, and delta receptors. Addictive effects of opioids always occur through the activation of mu receptors. We do not know what's the role of kappa and delta receptors in the addictive process. That's not very well defined. So if you look at what is the pathway for people who are using a drug, let's say heroin, and people who use heroin over a period of time march on to become dependent on it. If you really want to reverse the process, they have to stop using heroin, not relapse into heroin use again, and go towards abstinence. That's the best possible option you can look at. And you need to wonder how many people can actually go through from dependence to abstinence. People who have been experiencing with opioid dependence will tell you, if you purely employ an abstinence-oriented treatment, which is the best option, that will be applicable to about 5 to 10% of the people. Nowhere in the world, people are giving figures greater than 10% of success purely with an abstinence-oriented approach. That is why we need to look at post-detox, what we need to do to people. And I think what is really pragmatic, what is practical, is to offer them harm reduction services. This harm reduction services could be very low threshold services, which can help them to prevent infections like hepatitis C and HIV, or you can provide them treatment with opioid agonists or partial agonists, and then help them to reduce the harms. So if you look at this slide, there are many options that are available for people who are dependent on heroin. Not the only option of an abstinence-oriented approach, but we can do several things. But the first step in everything is the detoxification. What I would like to do is to help people to understand detoxification is rather easy if you use a partial agonist like buprenorphine. Normally, when somebody walks into a hospital, wants to get detoxified from heroin, for example, or another injectable synthetic opioid, we usually initiate them on a sublingual buprenorphine as less a dose of about 0.4 to 0.8 milligram per day. And this can be titrated up. Usually 2 to 8 milligram is sufficient to control the withdrawal symptoms. Then after 10 to 14 days, we can gradually taper down the dose. So the detoxification is no state-of-the-art treatment. Anybody, including general practitioners who are well versed with it, can actually do this. Can we attempt detox with methadone? Yes, it is possible, but we need to initiate with a smaller dose because it's a pure agonist. So we start off with the 10 milligram and go slowly to 20 to 40 milligram, not aggressively like in buprenorphine. We need to go slowly to 20 to 40 milligram, and then we need to slowly taper down at 5 milligram per day. This is really another way of doing detox with methadone, where methadone is available in some settings. If you want to compare, how do buprenorphine compare with methadone in terms of a withdrawal management? Everybody will agree, including a Cochrane review, that buprenorphine is safer, is better to resolve the withdrawal symptoms very quickly as well as safely. So it is better to use buprenorphine. People are most likely to complete the treatment of detoxification if you use sublingual buprenorphine rather than methadone. So everywhere in the world, for detox with opioid drugs, buprenorphine is the preferred drug. Can we treat them with non-opioid medication? The popular drug that people would be talking about is clonidine, antihypertensive drug, which is centrally acting, alpha-2 adrenergic agonist. Unfortunately, it can only suppress the noradrenergic hyperactivity of the withdrawal. For example, symptoms like nausea, vomiting, diarrhea, cramps, and sweating all could be controlled effectively with clonidine. But unfortunately, clonidine does not help with muscle aches, insomnia, distress, and craving. So quite a lot of symptoms are unaddressed by clonidine. And so people will be uncomfortable if you just provide only clonidine. So we provide treatment with clonidine on day 1, 0.1 milligram, 100 micrograms, 8 hourly. We can go up to 2nd and 4th days every 6 hours. On the 5th and 7th day, we can make it a BID dose. We are starting to taper down at the end of 7 to 10 days. We need to monitor the blood pressure. Particularly postural hypertension is extremely common when we use clonidine at that dose. We need to check blood pressure every time before you administer the dose. The nurse has to be checking up. When the blood pressure is 90 by 60 and below, we probably have to withhold the next dose. And I think it's always good to monitor with the clinical opioid withdrawal scale. That's always a good clinical practice to use the scale, easy to administer and monitor the person. Always, in addition to clonidine, you give them something like NSAIDs for body ache, some sedatives to sleep, particularly non-benzodiazepine drugs are preferred. You can give a small dose of, like doxepin or dosiripin or any kind of antidepressant which having a sedating property. These are the drugs that are normally used to promote sleep in this individual. And if the person is having a diarrhea, you treat the diarrhea as a symptomatic treatment. So that's how we can manage in settings where opioid drugs are not available. Look at and say what happens. Detoxification is simpler and it is actually very safe. Nobody dies of a heroin withdrawal. Nobody dies of an opioid withdrawal. People die of an opioid overdose, but users are terribly perturbed. It is more of a psychological set that they are afraid of withdrawal symptoms. And a lot of times reassurance is very critical for them. If you look at this graph, and I think what is shaded is where you show that where people can be very comfortable in treatment. Whether you give buprenorphine, whether you give methadone, that's the best way to deal with. Or even if you provide a symptomatic treatment, again, people will be within this tolerable level. Within this discomfort is not there with even symptomatic treatment. There are days in which you have provided treatment when buprenorphine was not available. Thousands and thousands of people, you have provided treatment symptomatically. Even now, many practitioners are giving symptomatic treatment. It is helpful. If you combine an antagonist, precipitate the withdrawal, precipitate with naloxone, and then aggressively treat the symptoms, because you can reduce the treatment period of detoxification, that again is falling within the comfortable period. only when you do not provide anything to the person, he withdraws on his own. Those are the people who have very uncomfortable level of severe withdrawal symptoms. So I just want to emphasize that withdrawal is no big deal. So what I'm going to be proposing, post-detox, we need to maintain the treatment of opioid dependence with long-acting opioid agonists and partial agonists. I think number of people in this country, people from AIMS, people from NIMANS, I have been part of this. We've all been working very closely with the government of India. Thanks to the government of India, we have had, like the availability of sublingual buprenorphine in this country. We have been able to, advocate for it, and it is available in large number of government centers free of cost. And that is happening now because of the large evidence we have been able to gather over decades with this particular drug. So let me say, what is the rationale? A lot of people will still ask me whenever I go, what is the point of treating one opioid with another opioid? Doesn't make any sense to me. You're treating heroin with buprenorphine, which is also abuse-producing drug. There are people who use buprenorphine and abuse it. And what is the point? So I want to emphasize, there is no argument in public health that the best is the best. So if you look at and say, I want to provide an abstinence-oriented treatment, how many people can actually be helped? If there are 100 heroin users and you walk them through an abstinence-oriented treatment, only 90% of the people will not be helped. Only 10% of the people will be helped in the best possible way. What happens to 90%? But when you provide something like an opioid substitution therapy or opioid maintenance therapy, you can help many, many people in the process. So I strongly believe the argument cannot be best versus many. If you have a good public health practice, we should be considering a treatment which is applicable to many people. That's my rationale. The more important reason, which I think we have been pointing out to the government, particularly to the National AIDS Control Organization, which is the first one to accept opioid treatment for people who inject drugs, is the simple fact that we have gathered in my own city in the early 2000s. This data was actually collected in 2004 and 5. We published it only in 2009. And then quite a lot of data that was collected in 15 sites. And we pulled together and produced 2 mortality rates. This is the only mortality rate that was available to begin with. Now there are a few more centers to produce a mortality rates. We know people who inject drugs like opioids die earlier, die very young. And that's a very unfortunate thing. So it's a killing disease. If you really want to prevent young people dying of overdose, dying of HIV, dying of other diseases, liver diseases, and I think we really need to be thinking about treatments that can potentially reduce harm. I have 3 arguments why we must be considering opioid substitution therapy or opioid maintenance therapy, whatever name you want to call it. Some people don't like the word substitution therapy. I would rather call it as an opioid maintenance treatment with agonists and partial agonists. So the first thing is, you are shifting an individual from an illicit drug like heroin to a licit drug. If I am a person in the street using heroin, I am considered an illicit drug user. I am considered as a criminal. So my behavior is also criminalized. If I come to Dr. Naresh's Jodhpur AIMS clinic and receive medication from him, and he gives me buprenorphine, and I am receiving a licit prescribed buprenorphine from Dr. Naresh, suddenly from a criminalized behavior, my behavior becomes like a patient-like behavior. So you're shifting the behavior of the individual by actually shifting from an illicit drug to a medically prescribed drug. That's the first thing that happens with people. When you change the way we look at and the change of labels of people, people's behavior also change. We see that. Number 2, many people in the street are taking opioids in the form of injection. There are many people who are also non-injecting, but quite a lot of people who can become dependent earlier on are the people who inject drugs. Whereas by providing either methadone or sublingual buprenorphine, you are shifting them from injectable to a non-injectable preparation. With that, there is a tremendous amount of reduction of harm in terms of acquisition of pathogens like hepatitis C, hepatitis B, and HIV. So we are really doing a public health good by shifting people from injectable to non-injectable preparations. It is on this ground NACO has approved this. Number three, we are shifting from a short-acting drug to a long-acting opioid. This is the rationale on which Dahl and Nisbender, along with Mary Jean Krieg, figured out methadone as a very useful treatment in New York. I'm going to show you something very interesting. This was produced by Dahl and Nisbender nearly about 60 years ago. Unfortunately, it got actually published by the NIDA in 1982. But please tell me that this is a 6 decades old work. What he pointed out was very interesting. Dahl and Nisbender, the pioneers, said, if you look at the 24-hour life of the people who are on heroin, their life is always chaotic. If you use a traffic signal model, they are either in a state of ecstasy and euphoria, dysfunctional, or they are in a state of withdrawal. This happens multiple times a day. There are very, very few hours of the day they are in the normal green zone. So if I'm a heroin user in the street, my 24 hours is chaotic. I am dysfunctional. Suddenly, he said, I am going to shift all these heroin users to a long-acting opioid, because heroin is a short-acting. That's why you need to multiple times medicate yourself, dose yourself. So the person takes an average 3 to 4 times when he's on a heroin. He injects 2 to 3 times minimum. Sometimes he goes to 4 times. Whereas if you put a person on a long-acting opioid like methadone, that's what he did. Suddenly, people were not going through this intoxication. They were not experiencing the high. Neither they were experiencing a withdrawal, even though they were on a long-acting opioid. Just replacing heroin, which is a short-acting opioid, with a long-acting opioid, the chaotic life of an individual has been normalized, and in the 24 hours, he is remaining in the green zone. This is a very powerful argument he presented. Unfortunately, psychiatrists and physicians were not willing to listen to his logic. The police listened to his logic, and actually the police were the first persons to start using methadone to reduce crime. It was initially used in a country like United States as crime prevention. You shift people from heroin to methadone, the crime reduces in New York City. That was their logic. Later on, it became a gold standard drug. Unfortunately, methadone is the most researched drug in the world. Every country, before they want to adapt it, they'll say, I want my own trial. I want my own data. Nobody accepts somebody's data. Every single country has researched on it. So it, unfortunately, methadone is the most researched drug in the whole world. Now, if you look at the maintenance treatment, we have 2 drugs which are potentially capable. These 2 drugs are essential drugs by WHO list, which are methadone and buprenorphine. They have 3 functions. What is the advantage of giving such long-acting opioids? First and foremost, as I said during detoxification, you either provide buprenorphine or methadone. Obviously, the withdrawal symptoms go off. That's the first gain. The second gain is, even after the withdrawals come down, users will go back to heroin because they still crave for it. The craving is very significant and long-lasting and persisting. That's why it's been taken as a criteria now in DSM-5. And DSM-5 now includes craving as a important criteria, because craving is very important. And the craving as a thing can be suppressed by methadone and buprenorphine. And lastly, long-acting opioids such as methadone or buprenorphine can block the effect of additional heroin and other opioid use. So what happens if you really look at the trajectory of heroin users? They have no withdrawals when they take the medication, and they do not have craving. Still, they will say, for the heck of it, I want to go and try heroin because my life is otherwise boring. I just want to try heroin and see what happens to me. If they feel a high, they're going to continue to use it. Whereas if you have given them a long-acting opioid like methadone or buprenorphine, their opioid receptors are all going to be saturated enough, so much so the illicit drug will not be able to act on the brain and produce a high. That's the logic of it. So there are 3 ways in which a substitution therapy is useful: controlling the withdrawal, controlling the craving, preventing further use of an illicit drug. So there is a distinct advantage by using buprenorphine and heroin. In addition, people who inject drugs, you can use them as HIV prevention, as NACO has done as a primary mode of treatment for people injecting drugs. And secondly, nobody who's injecting drug can actually adhere to complicated regimens like ART regimens, when they are having HIV disease, AIDS, they cannot be treated with art medication because they can't adhere to the medication. Even simple tuberculosis, they can't adhere to the 6 months treatment. But whereas you put them on these medications, they are able to adhere to both TB treatment as well as ART treatment. And lastly, I think both injecting as well as non-injecting opioid dependent people can be effectively treated by buprenorphine and methadone. First, let me talk about my favorite drug, buprenorphine. Why am I favoring buprenorphine versus methadone? Pharmacologically speaking, of course, all of you know that it's a semi-synthetic drug derived from the opioid thebine. It's a partial agonist. So it's got a mixed agonist and antagonist property on the opioid receptors. It's a partial agonist having a very low intrinsic activity at the mu receptor. Mu receptor, as I said earlier, is the most important one with regard to addictive process. It also dissociates from the mu receptor very slowly. That is why the withdrawal symptoms are not very quick with that. Abruptly you stop it. They're not going to complain about withdrawals immediately, may complain about it a little later, and maybe it's protracted because there's a slow dissociation. At the copper receptor is an antagonist. If you take buprenorphine, it acts within about half an hour to 1 hour. That means you can effectively make the person to get elevated from a withdrawal symptom in a clinic. Right in front of your eyes, his withdrawals will come down if you make him to sit down in the waiting room. The peak clinical effects occur about 1 to 4 hours. The duration of effect, depending on the duration and dose of the drug, less than 4 milligram, it works for about 12 hours. Greater than 16 milligram, it can work about, like 3 days also. So what's the advantage? Since it's got a long half-life, we give once a daily dose. Higher doses have prolonged action, which means we had trials in Chennai where we are given trial with people thrice a week. So people can't come every day and get the medication. So by upping the dose, by doing a thrice weekly, we were able to successfully maintain people because of its longer duration of action by just upping the dose. So what are the side effects? Any drug comes with side effects. After all, it's an opioid. Obviously, constipation is the biggest side effect, with like in any other opioid. People can have disturbed sleep with that. They'll come and ask for a benzodiazepine from you. You have to give a non-benzodiazepine sleep medication to them. Sometimes they complain about drowsiness and then say, I can't really be awake during the daytime. I'm not alert. Sometimes people complain of sweating and headaches and nausea. But unlike methadone, it doesn't increase the QTC interval. And occasionally it increases the liver enzymes. In my thousands of people I've managed in many settings, and I can say that the liver enzymes are elevated in very few people. Those are the people who are concurrently using alcohol in addition. We need to take a good history of that. Withdrawal symptoms, even abruptly withdrawal, so they have a low level of withdrawal, but the withdrawal symptoms can occur delayed after 2-3 days, and it can be protracted. So the reasons for the protracted withdrawal and the slow withdrawal is because the partial agonist is a low intrinsic activity as well as the slow dissociation from the mu receptor. Okay, what is the people will sometimes talk about the precipitated withdrawal and they get worried about it. This is a question of when do you give the first dose? I always tell my nerds, when you want to medicate for the first time an opioid dependent individual with buprenorphine, you do not only believe the history, not that users are liars. They have a tendency sometimes to say, I haven't used, when they actually use and come. It's not about they don't have a trust with the doctor. They don't trust themselves. They do not want to go through a suffering. It is a mindset of the user. So I always say, don't believe when he says that it's about, like so many hours since I've taken opioids. I haven't taken for 2 days. He'll come and tell you. But I tell him, people can never cheat you. People can say too many things. The people in the eye will never cheat you. All you need to have a torch to throw it. If the people is constricted, you do not give buprenorphine. If the pupil size is normal or dilated, if it is dilated, he's in withdrawal, you safely give the medication. The first dose is always best administered when the person is actually going through a opioid withdrawal. That's when he'll come and tell you, thank you so much, Dr. Alim, because you really helped me to get the withdrawals done. Second, it's a drug with a high safety profile. We worry about overdose with opioids. So many young people die in the country because of heroin overdose, because of pharmaceutical opioid overdose. But what happened with buprenorphine? Buprenorphine alone in excess dose cannot kill a person because it's got a ceiling effect. The ceiling effect comes with the partial agonist. We keep on upping the dose. suddenly it plateaus itself, and the ceiling effect prevents individuals from having an overdose. If we have overdose reported through buprenorphine, it's not buprenorphine alone. It's buprenorphine in combination, often with alcohol and benzodiazepine. That cocktail is a killer. Benzodiazepines and alcohol, along with buprenorphine, is what we have figured out many times as the reason for the overdose, not purely buprenorphine. So it's a safer drug to use. Can this be diverted? This is the biggest problem. This is the biggest problem. People are afraid to use the medication because I think, unfortunately, users might divert this medication and abuse it as an injectable preparation. So the problem is, yes, you have to, that's the reason why the government is insisting that it should be done under a, observed therapy. We have to observe the people when they are giving medication. But I think US has got over it. US, please, it's really not possible to keep on observing people. They have the office-based prescription. I know people in Australia, in UK and in USA, they get a month's prescription of buprenorphine because it's safer drug. They have the combination. Even in India, we have the combination medication, 2 milligram buprenorphine with 0.5 milligram naloxone. But technically speaking, if you inject this combination, you are not supposed to have withdrawals, right? And then you are supposed to have withdrawal. That's when it's supposed to be, naloxone acts very faster related to buprenorphine by injection. Sublingually, naloxone is not active. That's why the combination is helpful. So look at this. If you look at buprenorphine alone, its bioavailability is about 60% by sublingual method. Naloxone is only 10%. So obviously, when you give it as a sublingual, only buprenorphine is going to work. Supposing somebody injects, what happens? The injection to sublingual potency is 2:1 for buprenorphine, whereas it is 15:1 for naloxone, and also acts very quickly. So obviously, when he crush and inject it, naloxone acts first. So it's an opioid antagonist. So withdrawals occur. But you know what? This is very surprising. I have seen users crushing and taking it, not going through the withdrawal. They have actually taught me techniques of separating the naloxone from buprenorphine. They are street smart chemists. These guys can do wonderful things. But that could be a small number of people. Large number of people will be a deterrent. So I would strongly recommend in people who you're going to be prescribing office-based medication, I think the combination is better rather than a single standalone buprenorphine. What is the dose? I talked about its usefulness in 3 settings: controlling withdrawals, controlling craving, suppressing further illicit drug use. So drug dose varies according to what you want to do. For example, to control the withdrawal symptoms, most people will get controlled with 2 to 4 milligram. Nobody requires more than 2 to 4 milligram if you want to treat only the withdrawals. But if you give 4 to 8 milligram, large number of people will have reduction of craving. You can administer a craving questionnaire. You can find out the craving has reduced dramatically. But if you give anything up of 8 milligram to Indian clients, you will see they go back and use heroin, they go back and use any other pharmaceutical opioid, they come back and say, I did not experience any high at all. And then they continue to remain sober and abstinent from this. I have a cohort of people in my city who have been on this buprenorphine for a very long period of time. I've been maintaining them for such a long period of time. This cohort of the people that I have, they are alive, they are healthy, they are happy, they have a family, they are productive, and all of them on higher dose of buprenorphine. The moment you start lowering down the medication, and they will probably have craving and relapse into it. So the story is, you really want to maintain them well, you need to maintain them with the adequate optimal dose. I don't like the word high, moderate, and low dose. I like the word optimal dose. The optimal dose for controlling the illicit drug suppression is very high. Where is it contraindicated? As I said, in some people with severe liver disease, you have to be careful. And I think we have known people with HCV infection in my city. We are given buprenorphine in consultation with hepatologists. Really, when the liver functions is 3 times and less, I think hepatologists don't bother and allow them to give the medication. When it is ordinary more than about 5 times, you have to be very careful. Where you have to be very careful about prescribing the medication with other things. I'll be very careful allowing people to take benzodiazepines and alcohol. That's a constant advice we give in the counseling. Do not drink alcohol. Do not use benzodiazepines, particularly from the street. You can get alprazolam a lot. and diazepam a lot. Sometimes they inject diazepam. So all this should be definitely avoided. If somebody is to be treated with opioid antagonists, and I think they require large dose of naloxone to revert the overdose. Somebody is overdosed with buprenorphine. Because of the nature of it, perhaps you will have to require a higher dose. And then naltrexone, if you give suddenly without your knowledge, sometimes it happens. Some other aggressive people, without knowing, they just start him on naltrexone very quickly after starting buprenorphine. They might have a delayed withdrawal symptom. That could be agonizing for people. Opioid agonists, can it be given for people? Very difficult to achieve analgesia. So you have to tell your physician he's going to plan with the analgesic treatment with the opioid agonist, to tell him he's been maintained with buprenorphine. This is going to be very difficult to achieve analgesia with them. And drugs like, because it's a cytochrome P453A, like 4 metabolism it goes through. The inhibitors like ketoconazole or protease inhibitors, which are used in HIV treatment, you have to probably increase the buprenorphine level. This is theoretical. Clinically speaking, we do not make any adjustments either with inhibitors or with inducers like anti-tuberculosis drug like rifampicin or HIV medication like nevirapine or efavirenz. So these drugs, we safely give them. You got thousands of people are on ART medication, TB medication, and buprenorphine. They're doing extremely well without dose adjustments. Buprenorphine and women. This is a very tricky one. I think everybody who is in this field of opioid dependence will tell you the best for opioid dependent people is to be on a maintenance treatment. Either those days with methadone, one place where aggressively methadone was promoted for pregnant women. Today, we have replaced methadone with buprenorphine. It's a very safe drug for women, because I have actually been in the wards, the pregnancy wards, where in opioid dependent women have been delivering, because sometimes the neonates go through severe withdrawal with heroin or even with methadone, but with buprenorphine, that's much less. The withdrawal, neonatal withdrawal syndrome is very less. So very happy they go through a very safe delivery. And also, the buprenorphine appears very low concentrations in breast milk. So probably, this could be, a good treatment. This is not researched very well at the moment, like in pregnancy, but still I would say that it's a very safe drug for even lactating mothers. So, but only thing is, I would prefer people to give the monotherapy, not the combination therapy, because we know that naloxone may not be the good one for pregnant women, but pure simple buprenorphine is one ideal for people who are pregnant. Another population, which I think is a growing population, which people are not at the moment tackling, because we have been put on an age criteria. I work in a government center. I can't really take people below the age of 18, because it bars me from taking people above the age of, only 18. So, but the real world, there are a lot of people who are young people who are suffering with opioid dependence. So even though we would want to give them abstinence as a treatment for them, many young people struggle, particularly street living young people struggle to maintain on treatment. So these people will be helped very much with, buprenorphine. I quickly compare methadone and buprenorphine. This is my good friend from France who gave me the slide in 2001 when we were debating about buprenorphine and, methadone. And he gave me this slide. It's anybody's choice. I think we don't have to really make a choice. It's not idli or dosa. It's a question of, whatever your menu is available, you can use it, or perhaps both are very useful. The thing about methadone is a full agonist, and it can produce significant fatal overdose in people. The good advantage is some of the people don't like sublingual preparations. Indian patients have problems with sublingual preparations, whereas methadone is orally active. It's actually nice syrups are available with methadone, and it is cheaper, relatively cheaper. In this country, somehow buprenorphine is cheaper. In any other country, methadone is way cheaper compared to buprenorphine. India is an exception. So the reason why I prefer buprenorphine, because of the safety, because of the low level of physical dependence, because of the protracted but mild withdrawal symptoms, long half-life, a good substitute for people with mild to moderate opioid dependence. Quite a lot of our clients have only mild to moderate opioid dependence, and carries less stigma in many countries compared to methadone, and a flexible administration schedule. I can even give it alternate days. It's a favorable drug-drug interaction. So I believe the clinical implication of the property of the drug, the ceiling effect, and the slow dissociation, being a partial agonist, helps us to decide buprenorphine as a choice of drug. And is there an evidence for buprenorphine as a maintenance treatment? We have at least, as of 2014 Cochrane review, there have been 31 trials which looked at the quality, and it is as good as methadone. A dose of about 16 milligram buprenorphine in India, equivalent of 8 milligram dose, is as good as a 90 milligram of methadone. That's the kind of a dose equivalent we really talk about. So it's as good as, methadone. Compared to naltrexone as a treatment, obviously buprenorphine is a clear winner. There is no comparison between the two things. So this is my first experiment with buprenorphine way back in the 90s. This is the clinic which was operated from a, a church, because the church gave me the space and the resources to operate this. And I think the data collected from such kind of things helped us to convince the government over a period of time. This is an article we wrote and then argued why the scale up of opioid substitution therapy is important. I think this particular journal article, which was written in 2012, was very important for us to convince the government of India to have about 300 odd centers and scale it up. And I had the opportunity to work in many countries. I was the first one to start the, triangular clinics in Iran, which consisted of methadone maintenance. And I think I learned everything on job in Iran, and then also worked in China. The first pilot trial with methadone was carried out in Kunming. I was one of the persons who was part of that, the first, pilot. And after that, I've been very closely working with China. China has about 1,000 plus OST centers around the country, mainly delivering methadone, and very sophisticated MMT clinics. And I think, the way Chinese do it. And in our own settings, we actually have something called an integrated care center. This is where the OST center is a center in which many other services are linked together. So such kind of integrated care center, which is able to put in certain places, we have found it extremely useful. The same place where the individual gets a TB test, he gets a ART after that, testing, he gets a counseling, he gets a STI treatment, all in one services are all linked together. Usually it's a general hospital-based OST center in which all the services are linked. We wanted to know whether such an integrated care facility would be useful for people. We looked at 15 sites and did a baseline assessment in 2012. And we randomized in the first quarter of 2014. And we selected 12 centers. 6 of them were integrated care centers selected randomly. Other were usual care centers where, the treatment that a person has to walk into so many clinics to get it. And we followed them up for 2 years and got an evaluation. The evaluation was done after 2 years in both the integrated care facility as well as the usual care facility. And the 6 centers which participated in the intervention was Ludhiana, Chandigarh in Punjab, Bilaspur, Dimapur, Imphal, Aizawl in Northwest. And the control sites were Amritsar, New Delhi, Kanpur, Mumbai, Surat, Lungai in, northeastern India. So 6 and 6, this was randomly picked up. And then we really realized the integrated, co-located models can actually provide services to large number of individuals. These centers attracted quite a large number of people. We need to really match the intervention dose with the size and the needs of the population. We did not have the resources. This was a research trial funded by NIH, which is a largely funded trial, but then we have the limitation. So I do believe these are the way forward for people with people who inject drugs and people who use heroin. And last one, is naltrexone useful? A lot of people may be swearing and saying that naltrexone is very useful. My problem with naltrexone is, of course, other than the problems we have, it's an extremely useful drug when it comes to alcohol dependence, when it comes to opioid dependence, for which was originally given. I think the problem is extensive dropout rates in naltrexone. I was one of the persons who've been giving naltrexone from the 1980s onwards, and I had more failures and successes with naltrexone. We had to have, people who just maintain with naltrexone alone and then maintain abstinence. So maybe the extended release naltrexone, which is given in a monthly injection, may be more helpful than the oral one, but unfortunately, it's not available in India. I know I've been rapid for the want of time. I want to take questions and answer. I want to say opioid dependence must be seen as an enduring brain disorder. We certainly believe that it's an enduring brain disorder contributed so much by psychosocial factors. Detoxification is an initial step. It is easily and best done with a drug like buprenorphine with doses between 2 to 8 milligrams. Clonidine may be an option. Symptomatic treatment may be an option. but I think the vote will be in favor of buprenorphine. In terms of maintenance therapy, there are two standard drugs only, buprenorphine and methadone. And I would prefer buprenorphine because it's got a favorable side effect profile. It's a flexible dosing. It's got a less abuse potential. It's got demonstrated efficacy in controlling withdrawals, in controlling craving, and preventing further use of illicit heroin and other use. So thank you so much. I'll be very happy to take any questions. And thanks very much for the opportunity.
Thank you so much, sir, for a wonderful presentation. Over to chairpersons, please.
Dr. Tarpada, sir, you are muted, sir.
Yes. I want to tell you that in 1987-86, Dr. Mohan, professor of psychiatry, UGB, they had a group. They had advocated for starting clinics for methadone from government sites, but it did not take up because talking about methadone, as you told, the buprenorphine may be better. That is the thing I want to tell. So that is not take up. So now we can discuss the questions. So that when we start the questions discussion, then we will. Okay. Please, question to question.
Okay.
Shall I read through the question, sir?
Sir, I can actually, I'm going through the question.
That will be
Some
great, sir.
overlapping issues are there.
There are many more questions.
So way too many questions. I think reading will. I'll just keep answering some of this very important thing that that been people bothering. So first and foremost, let me say, clarify. There are very difficult questions. I will deal with them first. Questions are about, how long will you provide a maintenance treatment? This is the most difficult question for anybody. People who work only in the research field will tell you as long as the patient wants. Because in methadone maintenance treatment, for which has the longest history, I think people have been on methadone for decades. One of the reasons it's also been stigmatized. This guy has to go to the methadone maintenance clinic, obtain the methadone in order to be all right, right? So with buprenorphine, I'll tell you my clinical experience. Sometimes clinical experience is different from a research experience. The clinical experience of having worked with buprenorphine for decades is, at least I can tell, I have a 20-year plus experience with buprenorphine, consistently giving that in a cohort of people in this city. Three things happen. One, a group of people who have been having mild to moderate dependence, who have a very good social support, and who really have functional, who have a job to hold on. And these people very quickly after treatment with buprenorphine come back to you and tell you, I think I've stabilized my life. I want to come off buprenorphine. Help me with buprenorphine detoxification. And I would say this group of people have been detoxed and they are maintaining well. This is one good group, because it is not due to the clinician, it is not due to anything. It is the social factors. The social factors are significant family support, significant job support, and I think their ability to function normally. And then most often they have suffered from a mild to moderate opioid dependence. And primarily it's been non-injecting. The second group of people are people who've gone through a lot in their life and then who struggled a lot, who really are motivated. And after about a year or two treatment with buprenorphine, they come back and say, I want to really make a try. I want to come off this medication and try and see whether I can stabilize myself. Provided they have all the support factor that I'm talking about, they can also be supported. The last group of people are the ones who give up and go back, give up and go back, and then throw up their hands and say, I need this medication as long as you can provide me. So there are three distinct groups we have. But it is largely better than not treating them or treating them with only antagonist-oriented treatment. But I think the secret sauce of success is retention in treatment. Even after they abstain from treatment, we tell them, come and visit us once a month. Because after all, it's cost free for you. Come and visit and say hello to your counselor, hello to your buddies, hello to people with whom you have recovered earlier. It is always a reminder for them to go back and come and remind themselves. And some of the people who are used with them can go back. I don't want that to happen. So retention in treatment is a vital thing. So family support, psychosocial support, and then, and lastly, I think the factor of, binding with another group, which is actually remaining abstinent. We put people who are recovering together and they all attend the NA meeting sometimes together. Even though it's a harm reduction program, India is one country where NA groups accept all these people, even on buprenorphine. That's a very good move by the Indian NA groups. So that's also very helpful. And then retention treatment. All this put together, they are better. So the question is, if it is a long-term maintenance treatment, should it only be restricted to IV usage? My logic is no. I'm a strong advocate. So are the people from AIMS will strongly argue and say it should also be reserved for non-injecting drug users. My logic is, if somebody is a non-injecting drug user today, if you do not help him with the treatment, he's most likely to transit into injecting. Injecting is not a choice. Injecting is a question of economics many times. I do not want to be spending that much of a money when I increase my dose more and more and becoming more and more tolerant. I need cost to be reduced. The only way I can reduce a cost by increasing the efficiency of the drug by injecting. So it's not by choice. By given a choice, I don't think many people would have taken injection to begin with. It is not by choice or the circumstances, sudden unavailability, and then they're desperate. So I would say I would not discriminate between injecting and non-injecting. The criteria is dependence. The person is not dependent on opioid, you do not provide treatment to them. It's as simple as that. We do not provide opioid usage treatment. Only people with opioid dependence we provide treatment. And I think, can we treat people like tramadol and dependol, like these kind of people with buprenorphine and methadone? It's a very difficult choice. But I tell you what, today what we are seeing in this country is very peculiar. My friend Dr. Shweta Raghavan, who is asking this question, works in a clinic in the Institute of Mental Health in Chennai, and she sees any number of young people taking tapentadol. It's a tablet which crush and then they take the injection. They land up in the clinic with multiple abscesses, and you don't want to address that particular problem, and it's a serious issue. Now, I think anybody who started to inject these drugs and then abusing it, they deserve treatment if they are dependent on opioid. So it doesn't matter what opioid they are on. And I would only be hesitant to use people who are not dependent on, like simple opium users. There are several older people in this country who use opium, and I think they've been very happy. And I don't think we should shift them to buprenorphine. And I think they are happy with opium. I would want to listen to I like to listen to them. I don't want to call them as opioid dependent people, and I leave them in peace. I don't know, whatever it is. That's my way of looking at it, personal opinion, but not to be forcing it on anybody. But I don't really believe that, somebody is not dependent, we should be providing treatment. And
sir, we can help you in taking the questions from the chat box. Myself and Amrit.
Okay. How important is to know the receptor binding potential of different forms of opioid when we plan to shift from one form to the other? I think Tanmay Agarwal's question, a great question. The thing is, we focus on mu receptor. And I think only partial agonist like buprenorphine has a very slow dissociation. That's actually advantageous. That's advantageous. The only disadvantage is that, you don't just start on this when you are actually starting, like the person, that the withdrawals can happen later. Don't tell the guy, say nothing would happen to you. You say you stop and nothing happens, but usually you have it a little later. So helping them, psychoeducating them is more important. That's where it is important. Otherwise, that is really not going to be clinically very, very useful for you. Please define opiate dependence in medical terms. Dr. Rupinder is saying that's a very interesting question. I think I do not want to repeat what people in DSM-5 or ICD-11 have articulated as dependence. I think the concept of now is very, very different. They're saying people with dependence, any dependence for that matter, it's a brain disorder, obviously because it involves brain pathways of reward memory, and other important related learning and related functions. So obviously, this leads to certain neural circuitry disturbances, which make the individual to crave for that particular substance that is preferred, either for a euphoria or to alleviate the distress. And obviously, I think the confusion comes because, the differentiation between use and dependence is very tricky. And often the change, the transition occurs very smoothly in the people life. We never know what's happening. But there are three things that happens. It's not only by problems alone. Problem is one dimension. Dependence is another dimension. Often these two things intersect with each other. But I think with regard to treatment, we focus mainly on dependence criteria. As elucidated, if you really look at, there are very, very common things that are common between ICD-11 and DSM-5. If you look at, this is one area where which there is a, there is a kind of a confluence in the way of agreement about dependence argument. So the dependence on any particular drug, the criteria is the same, excepting that the withdrawal features that they are defined in opioids may be slightly different from other, are different from other drugs. We don't have to use cows every time. The cows, decided to just to say that, it's usually useful in the initial period in the opioid withdrawals that, when you're giving medication like clonidine and you just want to adjust the dose. Buprenorphine can be easily, titrated up. So I think we just use the scale. It's a really easy, simple scale to use. It helps us to understand where we are. And splitting the buprenorphine dose, I don't see maybe logic in it, because even though a lot of clinicians would think that that's a very useful thing to do, even a long-acting drug, why would somebody, it makes now theoretical sense to me, but practically some people say, I would rather give it, split it and give it. People are very happy because you give it once in the morning, once in the, particularly in the initial period, till they get convinced. It's a matter of, convincing people. Are there any other questions that you see, Dr. Naresh?
Sir, one was not directly related, but the maximum dose of clonidine in detox.
Sir, I have never exceeded 600 micrograms. Most people, even after 300 micrograms, they have had quite a lot of hypertension, experiencing hypertension. Very young people, robust people, they don't have any problem. But we up the dose of 300 milligrams because I've tried it as an outpatient basis a lot of times. So when you are inpatient, it's a totally different story. You can really rigorously monitor. When somebody is on outpatient basis, you don't want them to have a hypotension and partial hypertension and fall and hurt themselves, and that could be significant dangerous. I would say 300 micrograms is what generally I go up to easily as an outpatient, unless they are admitted as an inpatient. After that, I think, symptomatic treatment is what many people still do. We give NSAIDs, we give, anything that is working. I think the clinician's choice. I'm not going to impose anything. Everybody would prefer something or other. And I think that's useful. As I said in that particular graph, any treatment is better than no treatment. It's as simple as that.
Sir, can I ask a question, sir?
Yeah.
Sir, which are the cases when you decide that you have to go to 600 micrograms, sir?
So when the person's adrenergic symptoms are not still settling, particularly when he has, adrenergic symptoms like sweating and close flash and all that, all these adrenergic components is still, because the primary component of giving clonidine is only for that. It doesn't address the pain and other things. So the adrenergic component itself is not improving. That's when you increase the dose. But it all depends on the question of whether it's helpful and how much of a side effect the person is experiencing.
Sir, is it in any way related to the dosage of drugs which the client is taking, or is it the adrenaline rush that is idiosyncratic?
It's a very difficult question to answer. I have been able to not correlate the severity of opioid dependence with anything.
Sir,
The severity of opioid dependence is easy to calculate with the medication that I have administered with regard to buprenorphine. I can easily say that. Because after all, it's opioid tolerance is a little high for these individuals. But with regard to clonidine, I can't say the same answer.
But I would like to help, sir, since I used a lot during my PG time and later this molecule conventionally at PGI, and here also we are now trying. So good that start with low. Again, 300 microgram is a general choice, but if patient has the risk, then further lesser, just 200 microgram. But yes, mainly just to address the Dr. Amrit's question, if the withdrawal is still not settled and there's no side effect, because mainly the withdrawals are guiding how much to start, but always to start lower than one can hike up. Lexicon says up to 2 milligram one can use clonidine for various purposes, not opioid withdrawal. But again, generally psychiatrist is not able to go till that because people don't tolerate, or generally they are settled with the lower dosages. So
my problem is I have not used it in the inpatient settings at all. I usually have used it in, outpatient settings. And that's where my problem of giving more than 300, maybe, like PGI gives it in inpatient setting, and then they have a large experience of doing that.
yes, yeah.
So for a long period of time, I've been a person who've been, falling on the other side, biased towards, opioid agonists and partial agonists. Maybe it's a personal bias. And I think that limits my experience.
Sir, what is the range of cramps and muscle aches that you see, and how do you manage that?
So it can be very, 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 very disturbing. That's why I prefer drugs like opioid agonists. It takes away every possible symptom that we are talking about. When you're giving symptomatically, you have to go symptom by symptom and say what medication you're going to give, what medication to give. A lot of reassurance is required for them. Even though, sir, in many countries, people have been managing in the past without any treatment. The cold turkey treatment was practiced in countries like Malaysia, Singapore for long periods of time. So obviously people have survived that without any problem. So it's just a question of waiting for a period of time. It's a question of providing a humane treatment. I feel if you really want to provide a safer, humane, comfortable treatment to individuals, since you have buprenorphine available in this country, use it as well.
Sir,
Yes.
how should stock buprenorphine, and what are the checks and balances there? How to procure it and store it?
Oh, there is, of course, laws and rules and regulations that govern it. I do not want anybody to violate it because it is a drug that comes under this NDPS Act. You have to be very careful. And of course, it's not classified in the same range like other narcotic substances because the medication to be used, the class is different. Even then, there is no way you can flout the rules and regulations. Anybody and everybody, I think government centers, there is no problem at all because they strictly follow the protocols. And so they actually help. Private centers, I would request them, really, really request them, beg them actually not to violate rules, because if one person violates, it kind of, contaminates the whole system. Yeah, good medication cannot be painted, because of the not following certain rules and regulations. So strictly maintaining, adhering to this. See, we have also other medications, right? Psychiatrists sometimes use. And I think the laws are not very strict with them. And in fact, we should be following the same thing with methylphenidate, whatever. But I think with buprenorphine, the lens is very much on by the, group. So you should be very careful. I would not want any psychiatrist or anybody who's using it to violate it. Please go through state by state. There are some differences, but I think there are very clear guidelines, simple guidelines, not very difficult to use. And then, from procurement to getting the license and storing the drug and how much to be storing at a given point of time, how to give it, how to keep the register, how to maintain the patient. Everything is clearly well written. And I think if somebody is interested, probably I can supply you with all these materials that are required. I think it cannot be explained to, over a period of a seminar, but I think I'm happy to help with anybody who wants such kind of information. These are all done very diligently by people. I think it's a very easy thing to follow.
We have
Yeah.
two arms being raised. Can you?
So one thing I know, like a lot of people have asked, I think I missed this question, is how do we treat buprenorphine addiction?
Yeah.
So what if the treatment drug itself becomes a, a drug of choice? This is a strange phenomena that has occurred in the country because the usage have been introduced to injectable buprenorphine rather than the treatment with sublingual buprenorphine. This is the problem. So I still recall in my city, post the former Prime Minister's assassination, very close to my city, suddenly we knew that the other country groups were involved in heroin trading. Overnight, these people disappeared after the assassination, 40 kilometers away from Chennai. So Chennai woke up to find out that there is no heroin available in the market. So thousands of heroin users in the city suddenly transited to an injectable buprenorphine because injectable buprenorphine was manufactured in the outskirts of Chennai by a pharma company then. So most of the people were actually getting an illicit supply of it and injecting it. So within about 6 months, I had in my hand people who were actually injecting buprenorphine. And that's a serious problem. I do not want anybody to inject any opioid, leave alone buprenorphine. There is no good opioid to be injected, right? Only in medical reasons, for medical purposes, completely under supervision, you can provide morphine or pethidine or pentacillin or, like buprenorphine. All are useful drugs, but only under strict supervision by physicians for particular reasons. But for dependence, injectable buprenorphine is a very dangerous thing. So I think those people need to be treated. All we need to treat is, shift the injectable buprenorphine to sublingual buprenorphine. It's as simple as that. For people, I very, very rare for people to just use sublingual buprenorphine alone as a substance of addiction. Because, most of the people say, I'm using buprenorphine. You go back to the history and say they are injecting it. They crush and inject it. They want the injection. That's what gives them the euphoria, not the sublingual buprenorphine. The dose that they are given, that's not going to produce any euphoria. They want to increase the efficiency of buprenorphine at least twofold by injecting the same drug or combining it with a cocktail of, antihistamine, diazepam. It's always a cocktail. It's not, I think in those days in the 90s, our boys will say, I'm taking CAT, which is a Campos Avil Tidijasic, which is the brand name of buprenorphine that time. So I'll say I take CAT. So what is a CAT? So they're taking this combination, these cocktails of diazepam, antihistamines, and buprenorphine. So I think those are serious problems. We need to treat them. The only difference is treating buprenorphine dependence itself, particularly when they've been maintained on, let's say, 8 milligram for a long period of time, they want to wean off. It also requires treatment. They have to be provided detox purely with no other opioid agonist. There we have to manage with how Dr. Naresh is saying, I will manage them with only symptomatic treatment, including clonidine. That is very easy. It's easy to come off clonidine from buprenorphine than to come off from a heroin. So there is a vast difference. They are all effectively managed with 300 milligram, provided they have all the social support that I'm describing. It's easy to provide the detox and maintain them beyond that with no drugs. Sometimes they say, give me naltrexone. That's the only time I give naltrexone to people who have been maintained on buprenorphine, weaned away from buprenorphine, wanting to take the naltrexone and taking those naltrexone. That's the only group of people in which I would say naltrexone is extremely useful.
I think Dr. Sita wants to.
Yes.
Yeah,
Dr.
sir,
Sita,
may I ask
unmute
you?
yourself.
Yes, please.
Yeah, sir, you mentioned about babies and women. What is the scenario in India and what happens to those babies?
No, the neonatal syndrome, as you realize, is not a serious issue, even in children who are born for heroin-dependent mothers. They go through this agonizing, the crying and other things that they go through. I think the pediatricians are helpless. So we just have to reassure the pediatrician. It's more for the pediatrician and the mother, and the child is, of course, discomforted. So I think we don't have any special clinics here, like in Australia, where children can be managed effectively for neonatal abstinence syndrome, because the number of cases we have is very smaller. At least, like in many, many parts of the country today, opioid dependent women are far less compared to this. A disproportionately higher number of men compared to women. Not to say that the women are usually, it's a hidden population. We've seen large number of people, mostly in northeastern India. We have worked with them. And I think we have gone through them. In Chennai, I know that I've been with those women who are delivered. I've been there, part of this, delivery period, and then making sure that the pediatrician helps with the neonatal syndrome. Today with buprenorphine, we don't find it a huge problem at all. It is very, very manageable. They don't even recognize that the child has gone through this neonatal syndrome. But often, purely taking heroin alone, I think we really discourage that. Whenever we find an opioid dependent pregnant woman, we somehow convince them. But I think large number of people are the people who are willing to take the medication are the pregnant women, because they really know it's going to be very, very deleterious to their growing fetus. Because often they don't even complete pregnancy, you know that, right? So people who are on heroin, they have more increased incidence of abortion and other things. That's why you don't see that happening with kids, infants, except when they are maintained on buprenorphine.
So Paramveer wants to ask a question.
Yeah, please.
Yes, good evening, sir. Sir, it's very refreshing to hear such a good take on buprenorphine after such a long time. Sir, I just have a few comments and one question at the end. Sir, one thing that, sir, I've been treating patients in private setting with buprenorphine for around 2 years now, and I try to get them admitted to the IPD. One thing that I've noticed is that the initial dose of buprenorphine, even after the time of 6-7 hours after the last dose of heroin has passed, that there is some initial anxiety with that. So the second thing is, one of the major things that I have noticed is that people who are taking buprenorphine is how to take it properly. Many patients, they will just put it under their tongue, but once the liquid is formed, they just swallow it. So that is just one more observation. And finally, sir, one thing that I've noticed here in Punjab is that many people who are maintained on buprenorphine, once they go back and they report back that if they take alcohol, then they find that the efficacy of buprenorphine goes down. Like alcohol causes kind of an opioid withdrawal in them. Your comment on that, sir? And so finally, you were talking about medical opioids, like patient taking tramadol and tapentadol. Unfortunately, what's happened here in Punjab is, due to the lack of access to buprenorphine to many private psychiatrists, they have been forced to manage heroin with tapentadol or tramadol. So your comments on that, sir? And sir, people who have been taking very high doses of tramadol, like 3,000 milligrams up to 2,000, 4,000 milligrams, I don't think we have any other option than buprenorphine, because even if we offer them antagonist treatment, I don't think naltrexone will be able to block such a high dose of a medical opioid if they go and abuse it later on. Like such a high dose of tramadol will overcome the naltrexone blockade. So I think even in medical opioids, sometimes we don't have any other option than buprenorphine. That's all.
Paramveer, excellent comments. I'll tell you something about the way, that's why I said in my initial comment, I would start buprenorphine in individual only when he's in opioid withdrawal, and I'll use the pupillary size as my guide, because often people will not tell you the truth. And then, not because again, I'm not wanting to brand them as, liars, but I say it's a nature of the disorder which makes them to say such kind of things. They're worried about going through withdrawal. They're scared of withdrawal more than anything else. So I would use the pupillary size as my guide, the only guide to medicate. You are very right. I think Indian patients find it extremely difficult with sublingual preparation. I have not heard it from any other, like I've been interacting internationally with so many people. People don't have any problem with sublingual preparation in France, which is one country where buprenorphine is heavily used, even including general practitioners. And I think people in India have problems with sublingual administration. Asanapin, for example, an antipsychotic, completely went out of the market only because of oral and sublingual administration. Otherwise, I think this drug would have survived. Buprenorphine is orally inactive. It's not very active. So obviously, if somebody is going to swallow, the medication effect is going to go off. So you need to really teach. What smart drug users teach us? In the clinics only, I learned from the drug user. They are cultural experts. They are not just users. They'll tell you, don't give the tablet as such, sir. Crush it and make it into powder. And then ask them to put underneath the tongue. And keep on asking them to be there for the next 15 to 20 minutes, 30 minutes sometimes. Then ask them not to swallow. All these instructions are very clearly given and monitored by another drug user. And then it's really helpful. If you don't do that, invariably they'll swallow and then it becomes useless. So your observation is absolutely fine. And I think combination with alcohol, I don't know how alcohol would precipitate the buprenorphine withdrawal. I can't really look at it. If anybody can give an explanation to it, I'd be very happy to learn. But I think alcohol is a dirty drug. Using it with buprenorphine, that's a bad combination. So I always tell them, my education with heroin dependence clinics is largely devoted to alcohol again. We talk a lot. Our post-its are largely on alcohol because they think it's a very normative drug. Everybody else is drinking. My father drinking, brother drinking. Why can't I drink? Even after taking treatment. So we think we educate people about alcohol and its harmful effects to people on buprenorphine. And the third one, the last one, you are talking about people on tramadol and tapentadol being used as a treatment choice. As a psychiatrist who are working in the field, I would not want to touch anything other than buprenorphine and methadone, because this is only two drugs which is evidence-based. When I do not have evidence, I do not want to use the drug. They're again short-acting drugs. They're not long-acting drugs. They're not acting such long. So they're not going to give you this kind of a thing that the very essence of short-acting to long-acting gets repeated when you use drugs like tramadol. Just because it's available as another opioid. You know what? Lots of people, that's why it's also been now, new circulars you saw from the government saying that tramadol is now, is not available. So even people who wanted it is not getting it now. So that's what will happen. You can take a good drug into a bad drug by just people abusing it. So I would not want to use it as a treatment. As you are rightly say, somebody's taking a large dose of tramadol, or as my friend Shivita said about tapentadol, injecting dependent use, I would actually treat them with buprenorphine. I have no hesitation in treating them.
Sir, any comments on the implants that people are doing?
No
Naltrexone.
comments. No comments. To me, it's an experiment, and with no evidence. And I'm a person at the end of the day belong to science. So I want scientific evidence, because I took a long time to even get convinced that methadone works, right? So I had my own, a Puritan, working in a government institute where we believed as an abstinent-oriented physician. When somebody comes and tells me harm reduction, my first reaction is, oh no, don't tell me this. That's a natural reaction, I thought, for a young psychiatrist in the 70s practicing on, dependence. It's over the years, I was taught that harm reduction is not the opposite of, abstinence. I think it's one way to lead to abstinence. Now you think of harm reduction as a bridge towards abstinence, and we are all happy. And it's actually happening. At least in this country, it is happening. We are not divided on opposite floats. We are not opposition parties. We are actually working in the same way. I'm not against abstinence. I still think it's the best option. I'm only saying that's applicable not to many people. That's all I'm saying. I'm not against abstinence.
So is this?
But a lot of people are vouching for naltrexone implants, and is it not
but a lot
scientific?
of people would not constitute evidence, no, sir. A lot of people are saying for a number of reasons. And then I'm yet to see, naltrexone injections, I have evidence. Naltrexone injection as a long-term therapy for opioid maintenance, there is a lot of literature on that, American literature on that. But I would actually welcome that kind of an injectable naltrexone, not only for opioid dependent, but also for alcohol dependence, because it increases adherence to people. One of the problems with the naltrexone is adherence. It's as simple as that. Why would I take the medication which doesn't control my craving, right? Doesn't control my craving. Why is that? What is the thing in for me? As a user, I'll ask, what is in for me to take that naltrexone when it does not do anything with my craving, right? Whereas with buprenorphine, yes, a reason to take it. My craving is getting controlled. I do not experience withdrawal. If I take another illicit drug use, it's helping me. So I have a logic behind it. The same logic, naltrexone, yes, it blocks. Theoretically speaking, that's the best option. But should I take it? Nalesha did the biggest trial. My friend Navaratna worked for a WHO collaborating center in Kuala Lumpur, and then he did the largest trial with 40,000 people in Malaysia. His results clearly showed naltrexone is actually useless. So government followed it and removed it in Malaysia. And the same country is now adopting methadone and buprenorphine as a treatment choice.
Okay.
Alim,
Yes.
I think we should give Sir a break and call him again.
So you're saying you had enough?
No. I think we are tired.
I really want to thank
We will
Dr.
go on.
Naresh and Dr. Ray, I think Dr. Naresh in particular, for wisdom that you brought in with your vast experience of using clonidine. And I think I'm relatively naive in compared to you in terms of having used clonidine. Thank you very much for educating us on this, sir. Thank you. I appreciate that.
So we'll hand it over to the chairperson, sir, first.
For the remarks, and then to Dr. Tufanpati.
Now, yes, very much nicely evidence-based subjects, but there are a lot of things which are nobody could get the evidence documented. Number one. Number two, I want to tell one thing is the way of using opium are different places, different ways. Like I will give you an example. In the Andhra and the Odisha border, there are a group of people who take opium with guava leaves and boil it and take like hookah. So like that, regarding the children, till now in the rural areas, mothers used to give little opium to the child so that she will not cry much of the time. And subsequently, by the age of 5 to 6, she becomes little addict of the opium. So these are little observations. Now I ask the other chairperson to give his comment and conclude the session. Thank you.
Thank you, sir. I'll first ask a brief question which was asked today by a cardiac surgeon to me. A child is admitted here in the AIMS and he has cardiac illness, but because of those, the child is 2 years old. The family was giving opium, and again in Rajasthan, this is a trend. If any physical problem, then give opium and it helps. It's a socio-cultural belief. and now the child is dependent on opium, and but the age is 2 years. So what are the options that are available to us?
Really nothing excepting to allow the child to opt out from opium. Opium, I still think that it is quite harmless compared to heroin or other synthetic opioids. I think the natural opium was much less harmful, much less harmful. There were thousands of survivors. I've interviewed people aged 90 years in Myanmar who've been taking opium for 70 years, and they were actually healthier than me. So I wouldn't think of opium as a dirty drug. And I think it's a way we have converted opium into synthetic and synthetic preparations is where we have gone wrong.
Since
Sir,
the
there's a
OST is
question.
not
There's a-
indicated. I'm sorry.
So there's a question in the chat box corollary to this. Could pioneers like yourself recommend to OST centers to provide OST to minors, as we have loads of minors taking opioid? There's a corollary.
I think it's a
what
very
Sir is
tough
asking.
question. And I would, my mind says I would vote for 16 and above, who have been tried on abstinence-oriented therapy, failed miserably, reasonable evidence to believe that they are totally dependent and their life is chaotic and they are injecting. I would strongly think that they should be put on, because we have got enough evidence to say people above the age of 16 are benefited by buprenorphine a lot in several countries, including less developed countries.
Thank you very much, sir, for the comprehensive presentation. And as usual, to see you with smile, simplicity, very specific what are you answering, and very smooth, and on the top smart, what to address and what not to address. And I'm very happy to know, sir, that Dole's paper in NIDA 82, where heroin versus methadone comparison, because I was not aware. And again, the tips of buprenorphine initiation when there is some withdrawal, and the patient is also feel good after the dose and more connected with the therapist, and also the dosing tips to manage the withdrawal, craving, as well as other illicit use of the other drug. And again, you have given beautiful comparison about the buprenorphine, methadone, and naltrexone, and on the top talking about the journey, pioneering work, which many of the young psychiatrists don't know about, this whole struggle in the India to bring these molecules. And on the additionally, you also gave that this molecule can benefit very well to non-IDU subjects as well, just to prevent. And yes, in the same line, the Alan Marlett has also written in 2010 that there are particular groups which are against to harm reduction, but on the top, various international agencies have given the evidence and the support to these agents. And adding to OST, there are other more additional preparations on the harm reduction can also be used in the different conditions. Thank you very much, sir. And over to Tufan Pati, sir. And
Thank you very much. And first of all, I would like to compliment both the chairpersons for diligently conducting the program. And last but not least, I told when we have been chatting before that I am a fan of Dr. Suresh. He speaks well and he proved it. And as it was being discussed, we have seen from our student days that large number of patients in villages, Dr. Rai must have seen, they manage on tincture opioid. They do not disturb the social rubric. They don't disturb their family, and thus they are dependent on tincture opioid. And if you expand the thing is that they are opioid substitutes they have been using. It's a random concentration varies between the person who gives tincture opioid. In my UG days before that, tincture opioid was available in hospitals. And I very much support the view that harm reduction is a journey towards abstinence. They are not loggerheads at all. And the very fact we have experienced that when we are working in with a government backup, that forceful abstinence at times fails. It does fail, and it's very difficult. The cold turkey method is very difficult to achieve. But one issue is that I find many psychiatrists, even in our state, they refrain from using opiate substitution therapy. For legal obstetrics and for the meticulous attention one has to pay over time, and as a result, the patients are treated with substitutes like which we has been discouraged, like tramadol restrictor, just wash up the patient without going to the intricacies of opioid substitution. So therefore, it is essential that people, psychiatrists, especially psychiatrists, have a better knowledge and better insight to empower themselves with the courage to use it, because it is needed. And that then, thanks very much. It's not a question, it's a comment and observation. You can comment on the comment and then over to me.
Thank you so much, sir. Thank you, Dr. Suresh, sir. Opioid substitution therapy, I think that's repeated, but we are not yet experts in that. I'm one of the persons who is guilty of not using harm reduction as a mode of treatment. Let me be very honest and open in this forum. I think I treat a lot of substance abuse patients, but for me, naltrexone is still the drug of choice, in spite of what you are telling, and I've got very good results. I have not published any paper, but yes, I have a way of treatment, and I think everybody has a line of treatment, thought process, and I stick in spite of whatever things I do, whatever I've been taught, and I've got very good results with my patients. My patients stick to me, because I've seen many of many of my colleagues using buprenorphine, and those clients coming back to me after telling, no sir, we don't want to get into some things. So naltrexone, whatever evidence you have told, I accept it, but with a pinch of salt, sir. In an open forum, I am very, people are telling that harm reduction, psychiatrists are against it, but everybody has a way of treatment. And if we get results, and if we get good results, if our clients are happy with us, and I think another aspect is our patients, guardians are also happy with the fact. That's also a very important aspect, because patients generally don't come to us. It's not Punjab. We are practicing in Odisha, where I think most of the patients are brought by their guardians. So somewhere I have to also not just please the guardian, but make sure that the guardians come to a place where treated properly. Lest they don't go to a medicine specialist or a neurologist. Somewhere a little bit of compromise is made so that everything goes in sync. And I'm not apologetic about it, but I'm very, very open about it. So anyway, I am working on my own thought processes also. So it's been a wonderful talk. Naresh sir, seeing your CV, Alim collapsed. We had to give him a CPR. 185 publications, so many textbooks. Alim has not read in his entire career, sir, the number of publications you have done. So thank you so much, sir. Your inputs, your questions were very good. Tarapat sir, thank you. Is the senior most psychiatrist in Odisha, the most famous and the most amazing maximum number of patients. So inputs from him, from the minor to how the cultural, the cultural aspects of opioids is very, very important. So that's because I remember a medicine case where a lady was having intractable diarrhea when I was doing my internship, and my professor just asked me, did you ask about substance? 14 days of admission, the lady we are not able to discharge. Did you ever ask one question? I told, what? Did you ask about opium use? I went and asked, madam, and she was 77 years. Why will I think she will be taking opium? Were you taking opium? Yes, I used to take it every day. Now in the hospital, because of fever, I'm not taking, I'm having intractable diarrhea. So those are small things, but in the whole scheme of things, they're very, very important thing. So thank you, Tarapat sir, for giving your input, your experience. Tufan sir, thank you so much. The whole musings team. Some people had their own point of views, but this is not a political front. This is an academic front. So we only are interested in discussing academics. So we apologize if anybody has taken offense to we not taking care of certain questions, but that's part of it. So thank you so much. Thank you, Torrent. Thank you to all of you. We had more than 320 logins today. Highest peak of 230. That's wonderful. So even if the topic is a good one, so that's wonderful. So 30,200, 300 something now today. And Suresh sir, if you could share your PowerPoint, we would be happy.
Please, it is. I think I can send it to Dr. Alim and you.
Yes,
Because I have the
we
emails
won't,
of both of you.
thank you so much, sir. Thank you all of you. Dr. Naresh, we'll call you again, call you for a talk. So be
Thanks a
ready,
lot, sir.
maybe on polysubstance or something. There's a lot of topic coming on. Suresh sir is always there with us. He's been guiding us. So thank you, everybody. Good night. Have a lovely weekend.
Thank you, sir. Thanks,
Thank
sir.
you. Thanks, everybody. Good night.
Good night, sir. Good night.
Have some
Okay.
opium and have a good sleep.
Thank you, Dr. Alim. Yeah.
Thank you so much.
Thank you, sir. Thank you, sir. Good night.
Okay, thank you. Good night.
Good night.
Close the meeting now.